told you that the temporal fiber arches over and inserts into the top of the nerve, and the bottom one, because you're trying to avoid this phobia. But this papillomacular bundle is nasal, and so is this. These are both nasal. That makes a band across the optic nerve, like a bow tie. So, who has the tumor? Who wants to volunteer? So one of these is a tumor, and one is glaucoma. Which one's the tumor?
The bottom is the tumor.
The bottom one's the tumor. Okay. Why is this one the tumor? So it's respecting the vertical meridian. That's bad. So the junctional scotoma means it's just one eye, junctional scotoma traqueare, or it's one eye plus the other eye has a superior temporal. This is just bitemporal. So in glaucoma, it respects the horizontal. It's in the nasal field, and there better be cupping. And in not glaucoma, bitemporal rather than nasal, vertical rather than horizontal. So this one is the easy version of who has the tumor. Okay, the bottom one has the tumor. Like the security guard at my hospital, my friend Bob, he knows that that's the tumor. How about this one? It's respecting the vertical. It's denser inferiorly. It's homonymous. This is pi on the floor. Where's this one? That's the parietal lobe on the left side. So I told you that one of the things that ophthalmologists need to know is it glaucoma? So this is called the Goldilocks principle. The Goldilocks principle means it can't be too much or too little. So this little girl, Goldilocks, she goes into the house of the bear, she drinks their food, the porridge. The first one was too hot. Second one was too cold. And the last one was just right. This is our planet. We're the third planet from the sun. If you go one planet in, Venus, or two planets in, it's just too hot. It just burn you up. If you go one planet the other direction, it's too cold. All the water on Mars is frozen. So we have to be just right. So is this glaucoma? This could be glaucoma, but it's too vertical. You see that? Too vertical. So this is a fail on the Goldilocks principle. And so now you've got to look at the other eye, and when you take the two fields together, this is a left denser inferiorly homonymous quadrantenopsia. This is pi on the floor as well. But in the book, the way they draw the pi on the floor, it's so obvious that it's pi on the floor. But in the real world, there's all this drift across the meridian. This is a real world. So in the real world, the field never looks like in the book. Okay, the book is a book. This is people. So this patient has a cataract. They were told they have Fuchs, endothelial dystrophy, cataract, and glaucoma. See, they really have a cataract. See this yellow thing? It's a real cataract. And if you do this endothelial gutata, it's really Fuchs and a cataract. However, the field. What's wrong with this field? It's too vertical. And see, there's nothing in the other eye. What's the name of this field defect? Now you can say the thing you said. What's the name of this? The junctional scotoma of traqueare. But they thought it was glaucoma. They bring the patient back. Now it's starting to be over here, you see. So you've got a field defect that's starting to affect your center vision, and you have the superior temporal defect in the fellow eye now. What's the name of that one? See, it started as junctional scotoma of traqueare. It started as one eye only. And then it became superior temporal in the fellow eye plus optic neuropathy in this eye. This is the junctional scotoma. They're both junctional. And then they brought the patient back, and now, what is the name of this? This is the bitemporal. You see? But see, what's throwing them off is this, it goes across the meridian here. In the book, it's always straight up and down. Yes? So it started as the junctional scotoma of Traquair. It became the junctional scotoma, and now it's clearly bitemporal. And you see right there, they wrote at the top, question mark, not glaucoma. Of course it's not glaucoma. Too vertical, too fast a vision loss. Too bad for you. Goldilocks. Pituitary adenoma. Your buddy, the snowman. Remember the snowman thing? And it's going to have this atrophy, band atrophy. So the band atrophy in the book always looks so obvious, but in the real world, it's kind of like bandish atrophy. Yeah, bandish. Cupping. The cupping, it's supposed to be up and down like this. What if the cupping is side to side? So if we just show you this one, this is glaucoma. But if I show you this one, not glaucoma. So together, this is called band cupping. So the cupping doesn't mean glaucoma. What you're looking for is, in glaucoma, it's got to be up and down, because temporal fiber, top and bottom, vertical notch, glaucoma. But what if it's like side to side? Wrong direction. Too horizontal. It was a pituitary. It's a tumor. See this tumor right there? So you need to know the Goldilocks principle. The field defect in glaucoma cannot be too temporal. It's got to be nasal. It cannot be too vertical. It's supposed to be horizontal, not vertical. It can't be too fast, and you can't have too much visual field loss for the cupping. And you can't have too much rim power. So if you have too much power of the rim, too fast of a course, too vertical of a field, or too much field loss for cupping, all of these are not glaucoma. And the main thing of all the fields we've learned, vertical step. That is the thing you're looking for, the vertical step. Too vertical. So every field you look at going forward now, you're going to be asking yourself a question. Is this field too vertical? Every field you need to ask it. Because in the book, it's so easy that this is this. Yes? How about this one? What is the name of this one? It's the junctional scotoma. So you're going to get so caught up with this bad field here. See that thing right there? That little tiny thing is everything. This is the junctional scotoma. What's the name of this guy? Monocular. This is the Traquair. See, it's nasal. This is the one you miss. Nobody misses the junctional scotoma Traquair when it's hemiopic and temporal. It's this one that looks like glaucoma to you, the nasal one. But this one is too vertical. Okay, too vertical. And it's just, the tumor just bends over there. Okay, see the banana? Just bending over there. All right, what's the name of this one? Pi in the, which temporal or parietal lobe? And the name of the loop? Yep. Which side is the lesion on, left or right? Left, because this is a right, denser superiorly. Could this be occipital cortex? Yes. This one's pi on the, okay, there's a special finding now. You see this sparing right there? What's the name of that sparing? Macular sparing, and that means you're sparing the occipital tip, and that means it's way more likely to be occipital or parietal. Pick. Occipital. So if it's pi on the floor or pi on the sky is temporal lobe, Meyer's loop. Pi on the floor is parietal lobe. If you spare that macula, that's way more likely to be occipital, because the tip has two blood supply, MCA and PCA. So this is called a macular sparing. So this is a right, denser inferiorly, macular sparing, homonymous quadrantenopsia. Which side is this on? If this is on the right in the field? Left. And is it sparing or involving the tip? That's called macular sparing, and that means it's more likely to be occipital or parietal. And because it's denser inferiorly, is it going to be the superior calcarine cortex or the inferior calcarine cortex? You just localize to within this much. No scan. The superpower. You literally are going to go to radiology and say, hey, we think this person right here has a left superior calcarine cortex infarct, sparing the occipital tip. Don't you want to go to radiology and show off? If you have a complete, the whole thing is black, you cannot localize that. It only lateralizes behind the chiasm. But what if you have cupping, and the cupping is going this direction? You see that horizontal cupping? Instead of this direction. And when you do the OCT, this atrophy, it has a name. What's the name of this atrophy? Do you understand what you're supposed to be doing? That's not glaucoma. Too vertical. Cupping is too horizontal. That field is a hemianopic field defect. So what causes that band of atrophy? The center of the eye is your fovea. Fovea, not the nerve. And that means the thing you call temporal pallor. Is this a temporal fiber or a nasal fiber? It's nasal. So you must unlearn some of the bad things you have learned. You have learned that this is temporal, but it's only temporal relative to the nerve. Relative to the fovea, this is nasal, this red thing, and this red thing is nasal. And that's a band or a bow tie of atrophy across there. You see the nasal fiber now. Who would tell you that that is temporal? The machine tells you that. On OCT, it's T-SNP, temporal, superior, nasal, inferior. Remember that thing? It literally is a liar. The machine, it's a liar. This red fiber is not temporal. It is nasal. This is temporal, this is temporal, this is nasal, this is nasal. Because glaucoma thinks they're the center of the optic nerve world, they named it for themselves. But that is not correct. Temporal pallor. If you see temporal pallor, you must look here. Because what you're looking for is the temporal pallor actually nasal pallor? And is the nasal pallor a band? And if it's a band, it's a tumor until proven otherwise. You understand how important it is for you to know. Now, this bundle here has a name. What is the name of this bundle? Yeah, it's in the macula, but what do they call it? Papillomacula bundle. You heard that word before? That is the wrong direction on a one-way street. It is going from the macula to the papilla, not the other way around. It's a one-way street. It goes macula papule, immacula to papule. Yeah? It's not a papillomacula bundle. It's a maculopapillary bundle. But you're stuck with this because retina also thinks they're the center of the world. But they're not, okay? Neuro is the center of the world. All right, you see the band? Here's the picture of the band. So if you see temporal pallor, you got to look right there. So if it's pale here and pale here, that's band. Do you see the band now? Yeah. It's so obvious now. Think about how many patients you've seen with temporal pallor and you didn't actually look at the nerve properly. All right, this is a wedge defect. See, it's on the same side. It's homonymous. On the Goldman, it doesn't look like a half. It looks like a wedge. You see this wedge? But it's on the same side. That means it's homonymous. It's not hemi because it's not half. It's like a wedge. Where is this lesion? What's that? So in A, it's a Goldman. You see that wedge? It's this thing, goes right there. It's like a piece of pie. Do you see the pie? It's like a piece of slice of pie in a triangle, but it's homonymous. Where's this lesion? The geniculate body. Which artery is out? The anterior or the lateral posterior carotid artery? See, it's involving the wedge, not sparing the wedge.
Anterior.
This is the lateral. You need to know this. The reason it looks like that is the blood supply, the geniculate. You see the geniculate body here. So medial horn, lateral horn. The green and the yellow are represented by that wedge. Do you see that wedge? And weirdly, the red and the blue are the above and below in the geniculate body. And so the anterior choroidal artery supplies the red and the blue. You see the red and the blue? But this middle part, that wedge, is the lateral choroidal artery. So let's go back to this thing. Do you see the wedge now? Yes? So that's wedge involving. That wedge is this green and yellow. That is the lateral choroidal artery. You got all this? Because until I just told you that, you probably would have no idea what this field is. But now that you've seen it, you'll never forget it. It is the lateral choroidal artery. It's a homonymous wedge sectorinopia. Homonymous wedge sectorinopia. Okay, is this the lateral or the anterior choroidal? This wedge is involved. It's lateral. Do you see it now? The wedge. The green and the yellow. A wedge. Do you see it?
Yes.
So it looks like this. Pac-Man. You see Pac-Man? And it can spare the wedge. Do you see the sparing in the top one? So that is geniculate, but it's bilateral on top. So that's sparing the wedge. Which artery is that when it's sparing? It's the anterior. What's the name of the artery if it's involving? They're both geniculate. This appears on tests all the time. It's super rare in the real world, like super rare, but it's so distinctive. Of course it's on the test, okay? This is a right, denser inferiorly, macular sparing, homonymous, and very congruous paracentral defect. So is this lesion on the right or the left if the field defect is right? It's on the left. And is it going to be sparing or involving the tip? Sparing the tip. And is it going to be superior or inferior calcarine cortex? Yep. And so that's what this is. Spares the tip. It's infarct. What's the name of this imaging study? It's MRI, but it's a special sequence. What's the name of this sequence? Our neurologist, do we know what this is? See when it's so fuzzy and you're missing the whole front of the eye? It's diffusion. It's diffusion. It's a stroke. All right, what's the name of that finding right there? Macular sparing, that MS, macular sparing. This field is on the right. It's very congruous and macular sparing. Therefore, the lesion is going to be on which side? And because of that macular sparing, it's going to be sparing the tip in the occipital or parietal or temporal lobe? Occipital. Which eye has the RAPD if it's occipital? No one. Which eye has the band atrophy? No one. There is no band atrophy, and there is no RAPD in an occipital lobe lesion. There's no pupil there. There's no cell body there. All right, this guy has this black thing way out here. That's the temporal crescent. Even though this field defect is on the right, which side is this lesion on? On the left. And that's because the crossing fiber, the nasal fiber, is what causes this temporal crescent. This is a monocular temporal crescent. Where's this lesion? It's on which side, right or left? Left. And that, remember where that crescent lives? Does he live posterior in the tip or anterior? Anterior, on the left. If I show this to the retina doc, however, they will say it's on the right side. Won't they? But they look in the eye and they see nothing. So, will this eye have a RAPD? Nope. Because this lesion is an occipital cortex. This is the temporal crescent. Monocular temporal crescent. Where's the lesion? In the most anterior portion of the contralateral occipital cortex. So this person has homonymous hemianopsia. It's complete. It's macular splitting. You see that? But this field only measures to here. And so you have no idea that this temporal crescent is spared in this person. So the person comes out of the machine with that field at the top. Now you have to test them with confrontation. You're going to put the finger here. They're going to say yes. And then as soon as they cross the midline, they're going to say no. Yes, 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 no. Yes, 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 no. So you're testing them across the meridian. And they say it's vertical. You got that part? Okay, here we go. Yes, 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 no, 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 no. And then all of a sudden, yes. So you're testing the temporal field. No, 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 no. All of a sudden, yes. The temporal crescent. The Humphrey cannot measure this because the Humphrey it stops at 30 and 24 degrees. So in every patient with a homonymous complete hemianopsia, you must take your finger in the temporal field eye and say, tell me when you see my finger. Yes, 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 no. No, 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 no. Yes. Occipital. You got this? You've never done this before. Ever. You just let that person there and you say, go get an MRI. But wouldn't it be great if you said, just give me 10 more seconds of your life? Yes? No, 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 yes. You have occipital lesion. It is sparing the most anterior portion of your occipital lobe. And you tell that to neuroradiology, and boy, will they be impressed. Won't they be impressed? You need to know that sometimes you have bilateral, juxtaposed. You see that it's a juxtaposed homonymous. See? It's left and right. It's like the BMW symbol. You see a BMW in there? It's like a checkerboard. So this juxtaposed homonymous checkerboard means you had an infarct on this left side, and now you have new hemorrhage on the other side. Juxtaposed. Is this sparing or involving the macula? Sparing. And that means the tip is going to be spared or involved on the right. You see this white thing? It don't go all the way to the tip. You see it? Yes. Macular sparing.
How do you know here which side?
It's both sides. So the old one is this hypodensity here. This is the old stroke. That was last year. This is today. Juxtaposed. So the patients sometimes don't notice they had the stroke from before. They only had the homonymous back then. What do you think this person's acuity is? 20/20. 20/20? Will they have an RAPD?
No.
Nope. The slit lamp.
No.
The pressure. The motility.
No.
The fundus exam. The OCT of the nerve. OCT of macula. Fluorescein angiogram. ICG. Ultrasound. Everything's going to be normal in the eye exam, yes? So you better do a field on every one of these unexplained vision loss. You understand what I've said? Nothing wrong with a person's eye. It's not an eye thing at all. So we're looking for the wolf. The way to find the wolf, you got to ask yourself a single question. Is this field too? Or is it horizontal? Horizontal? Glaucoma in your eye. If it's in the temporal field and vertical, that's bad. That's the wolf. Then you have to ask yourself, is this a junctional, a bitemporal, or a homonymous? All of those are the wolf. And the geniculate, what's it look like? Wedge sector anopia or sparing of that wedge. If it's involving the wedge, is that the anterior or lateral? If it's sparing that, anterior. And now that you've seen it, you know it forever now. And the tract lesion has the band atrophy and the RAPD. They're all the wolf. You understand everything I've told you. Look how much you've learned. in just 2 days. What if you were to come onto YouTube and just watch those videos? You'll know more than most ophthalmologists know about neuro. The reason we started that YouTube is nobody read anything I ever wrote, except other neuro ophthalmologists, and also only when you needed it. And my kid, who was 14 at the time, she's 22 now, that was 8 years ago, she came and said, Dad, you need to change the way you teach. I'm like, what do you mean? I've been teaching for decades. I know what I'm doing. She goes, no, nobody is going to watch a 1-hour lecture. Nobody. You need to convert the 1 hour into 3 minutes. I said, it's impossible. I cannot make it in 3 minutes. It'll take 30 minutes just to explain it. She says, nope, you can do it, Dad. I believe in you. That was her innovation. I said, this is hard to convert 30 into 3. She said, I know. It proves you actually know it. Anybody can teach it in 30 minutes, Dad, but only you can teach it in 3. Isn't that what makes her smart? Yeah. So my kid owns that site, the YouTube site. It's her company. She's the president, CEO, and sole proprietor of the YouTube site. Come and visit me. Because my kid gets like a penny every time you do it. She never asks me for money. Because her company pays for it. She never asked me for a single dollar. She's 22 years old. She didn't have an allowance. She never asked me for money. Age 14 to age 22. No, never asked me. That's amazing, don't you think? For a kid. All right. We're going to do the pupil now. Do you see the little person inside the pupil? So what does being a pupil mean? Like you're a pupil.
Student.
You're a student. Well, it also means the eye. Why? Like right now, you're a pupil of the pupil. Why?
Because the people study.
Well, the ancient peoples, when they looked into the eye of the other person, they saw that. A little version of themselves. That's so weird, don't you think? So when you look into other people's eyes, you see a tiny reflection of yourself. So you are a pupil of the pupil, and so you and I will see a tiny reflection of each other. This is called quantum entanglement. We are now quantumly entangled. The fact that we have shared a common neuronal experience means that one day in the future, I will have no existence on this planet. I will be long gone. Because you're young people, you will have a patient, and I will be there with you. That's weird, don't you think? And you'll say this, I remember this crazy Dr. Lee guy came to Kuwait, and he said, I would be telling you this. This is too vertical. And then he said this, Goldilocks. And it just stuck with me. To understand what's going to happen from us sharing this communal experience. It's why people like to go to the movies together, when you could just watch that on Netflix yourself. It's why people go to the soccer game together. You could just watch that by yourself on TV. But you don't. You're like, invite your buddies over and you watch it together. Yes? You could eat and nourish yourself by yourself and have the exact same nutritional content. But you want to share it with other people. Last night we went to this restaurant, Abel. It was fantastic. I could have just gone there by myself. It would have been the exact same food, but it wouldn't be 1/10 as rewarding or fun. Do you understand? It's not about the food. Just like this isn't actually about the pupil. It's about a shared neuronal experience. Do you understand what I'm telling you? All right, so big pupil, big ptosis, big problem. Which one's that? Imaging study? CT, CTA. If it's negative, you still have to do, because non-aneurysmal causes of third palsy are seen better with an MRI. Big pupil, little ptosis is still a third. You still have to do the exact same imaging. Little pupil, little ptosis, that one's got a name. What's the name of that? Warner's. Little pupil, big ptosis, that's actually cavernous sinus. either aberrant regeneration of the third nerve with the pupil, or you have a concomitant corners and a third, because that pupil is little. Normal pupil, but RAPD plus any ptosis, that's a big problem, because that puts the lesion right into the orbital apex, because the cavernous sinus doesn't have the optic nerve. And any combination of pupil and anisocoria is bad. Yes, any combination. Pupil, anisocoria, ptosis, bad. So we're only going to say worry or watch. Okay, we're going to practice now. Worry or watch. Okay, worry or watch. If it's pain, acute, ptosis, diplopia, bilateral, trauma, or kid, is that a worry or a watch? Worry. If it's asymptomatic, chronic, isolated, and long-standing, we're going to do a FAT scan before the CAT scan, family album tomography, or Facebook album tomography. We're going to look at all their photos and see how long it's been there for. If it's been there for 5 years, they're fine. Nothing. Okay? Is that a worry or a watch? If it's asymptomatic, chronic, isolated, and long-standing. That's a watch. You need to know about these topical tests. Pilocarpine, 0.1%, that's for Addis tonic pupil. 1%, that's for pharmacologically blocked. Aproclonidine, you need to know about cocaine, even though there's no cocaine here, because it's on tests. Because Canada has cocaine, and your tests come from Canada, you have to know about cocaine. Yes? And don't use the drops in the emergency room setting. Just scan the whole pathway, regardless. So in the ER, you can do the drops, but don't rely on those drops. Just scan them. All right, the very first thing you gotta know is when we shine the light in this left eye, and I swing from the left to the right, and that pupil dilates, what's the name of that finding? You need to know this thing. It's an RAPD, relative afferent pupillary defect. But when I ask my resident, when I swing from this left eye to this right eye, and this right eye has an RAPD, which pupil dilates? What did they say? I say, which pupil dilates? What do they say? If I swing from the left to the right, that's the correct answer, both. But what do they say? They say they're right. So what's the correct answer here? When I swing the light from the left to the right in a right RAPD, which pupil dilates? Not just the right. If I ask the resident, this person has a right RAPD, which side is the lesion on? What's the correct answer? Now that you know everything that we talked about, is it right side, left side, either, neither, both? This person has a right RAPD. Which side is this lesion on?
Can be both.
How could it be on the contralateral side? If it's the tract. Because the nasal fiber, the temporal field is bigger. And so if you have a right RAPD, that lesion could be on the right if it's pre-chiasmal, but it could also be on the left if it's post-chiasmal. So when I swing the light from the left to the right in a right RAPD, which pupil dilates? Right, left, either, neither, both? Both. If I swing the light from the left to the right in a right RAPD, which side is the lesion on? Right, left, either, neither, both? That's either. You guys know RAPD, but until I just told you all that, you didn't know that, okay? You need to know that. So when we swing the light and there's a right RAPD, if you ask the retina doctor, where's the lesion? What will they say? They'll say the right. But it could be the left. You didn't do a field. Because it's retina clinic. Why would they do a field? But you have to do a field. Even if it's retina clinic. Even if it's plastics clinic. So you need to know, where is the lesion? What questions would you ask? What else would you do? What's the most likely? And what's the workup to decide worry or watch? Okay? So when we swing the light from the left to the right, and this pupil dilates, this one also dilates. And that's because the pupil fiber innervates both Edinger-Westphal nuclei. That is, it's a bilateral, direct, and a consensual response. So if I ask the resident, if I cut this optic nerve right here, cut this, your vision will go to light perception. What will happen to the pupil size? What will happen to the pupil size if I cut your right optic nerve? Explain it to them. Don't you want to say it's going to dilate? Isn't that what you want to say to me? But what's really going to happen? Huh? Why? The other side. So, even though it seems like if you cut the right optic nerve, your pupil will dilate, the other pupil is holding that eye down. And therefore, when you have afferent disease, I cut your optic nerve, it cannot cause anisocoria. So if you have an RAPD and anisocoria, that's two separate problems. RAPD is afferent. Anisocoria is efferent. All right, if I cut that right optic nerve, what will happen? Nothing. You'll be blind, but the pupil won't change size. So even if you make this eye completely NLP, the other pupil will hold the pupil size. You understand how anisocoria is completely different than RAPD. One is afferent, efferent. They just happen to be in the same part of the exam, the pupil exam, but they're completely different in their localization. So the afferent pathway, retina, optic nerve, chiasm, tract, geniculate, does not receive the pupil fiber. The pupil fiber leaves before the geniculate. So when you have that wedge sector anopia, will you have an RAPD? No. That only occurs if you're in front of the geniculate. You got all that? The other part is right here. This thing is called a pretectal nuclei. You see, this is still afferent. This is where the efferent starts, the Ettinger-Westphal. This piece right here is afferent. And that means you could get damage right here, and it'll produce an RAPD. The name of that RAPD right there at the tectum is called a tectal RAPD. Tectal RAPD. You need to know that because it's on tests. It almost never occurs in the real world. But what will be the acuity if I damage this nerve here, this pretectal thing? What will be the acuity? 20/20. What will be the visual field? No. Completely normal, because that visual field fiber went to the geniculate, the radiations, and the cortex. What will be the OCT? So you literally are going to have someone who's 20/20, has no visual complaint, has a normal visual field, a normal OCT of the nerve and macula, completely normal fundus, but you detected a right RAPD. That lesion is in your brainstem. However, what will happen when the resident comes out of the room and tries to tell their attending, this person has a RAPD on the right, but their acuity is normal, they're not even complaining about anything, and an OCT is completely normal. What will the attending say to the resident? You don't know how to test for an RAPD. So you got to show it to them, okay? Before you put those drops in there, you say, hey, don't, I'm serious, doctor. Come look at this. Oh, yeah. What did the field show? Nothing. You literally have an RAPD, no visual loss. That is a pretectal RAPD, a tectal RAPD. You got this tectal RAPD? You're about to send someone out who has a brain tumor in their dorsal midbrain. Because you didn't think the resident knew how to test for an RAPD. No one knew that. Yes? So, size does not matter in neuro. Okay? Tiny RAPD has the exact same significance as whopping RAPD. RAPD just tells you where the lesion is, not why the lesion is. So please don't write in the chart question mark RAPD. Question mark trace RAPD. Question mark baby RAPD. The size of the RAPD does not matter. Just like papilledema, it doesn't matter. Trace papilledema, that's the same as whopping papilledema. Papilledema means you have increased intracranial pressure. So a little bit of papilledema is just as bad as a lot of papilledema. They're both bad. The size does not matter. Little third is the same as big third. Size doesn't matter. Yes? Tiny sixth, it has the same significance as whopping sixth. Sixth is sixth. Third is third. You understand? It's not like retina or cataract. Cataract, little problem. Little bit of macular edema, little problem. Little RAPD, huge problem. Size does not matter in neuro because we're about localization. All the rest of ophthalmology is about how bad it is. Little ptosis, little edema, little diabetic retinopathy, little. We don't care about size. What we care about is location. So even an unexplained baby trace RAPD, that is one bad baby. Okay. Is this a worry or a watch? We have an unexplained RAPD. Worry. This is a 12-year-old girl. She was seen on a routine eye exam by a well-respected, well-trained optometrist. Their vision was 20/40 and 20/20. They had a normal exam. They supposedly had no RAPD. They had a normal fundus. They had no history of strabismus, no anisometropia. The diagnosis that was written on the chart was lazy eye. Plan, come back in a year. Don't be lazy with the lazy eye. In order to establish a diagnosis of anisometropic or strabismic amblyopia or deprivation amblyopia, you must have an amblyogenic etiology. You cannot just say people have lazy eye. This is a study of 50 claims against optometrists, and the great majority was failure to look at the back of the eye. That was like most of the cases. Laziness in the United States is a super common cause of malpractice, not intelligence. The doc never says, I never heard of that. They never say that. They say, I didn't do it. That's what they say. I didn't swing the flashlight. I didn't do a field. I didn't do this. I didn't do that. You must do a field. Should you scan this? Why? It's too. You're going to get all caught up with this. See all this? Don't look there. This is the part that's dangerous. Don't look over here. Yeah. How about that thing right there? What's the name of this thing? This is the junction scotoma. Do you understand how the book field never looks like the real world? All right, so what happened? She came back a year later, 2200. They have that field defect. That's a junctional scotoma. It's a craniopharyngioma. The kid got hydrocephalus. Neurosurgery said we couldn't take the whole thing out. She went no light perception in both eyes. She's 13 years old. Don't you think you're going to be sad that you ruined the life of a 13-year-old kid? Everybody's devastated by this case. Family, the patient, the doctor, everybody's sad. The insurance company of the optometrist refused to go to mediation or settle. The case went to trial, $9.2 million judgment against optometry. Sad blind girl, angry parents, sad angry doctor. And after 30 years, this guy quit. Do you think he's going to remember the 30 years of patients that he helped, or he's going to remember this little girl for the rest of his life? You understand? He literally erased 30 years of legacy by one error. One. $9.2 million judgment. This is what her attorney said. This case stands for taking a full and adequate patient history, doing a complete exam, and learning what the patient's problems are before settling on a benign diagnosis of amblyopia. End quote. How do you spell trouble? Neuro Opt spells trouble. R-A-P-D. You must swing that light in any unexplained vision loss. You must do a formal visual field. In amblyopia, you have to have an amblyogenic etiology. Strabismus, anisometropia, deprivation. This poor optometrist inherited this patient at age 12. He had never seen her before. You are about to make the diagnosis of amblyopia on a 12-year-old. Don't do that. So, amblyopia when you're a kid, that's easy to diagnose. It's the amblyopia when they're not a kid anymore. That's the hard one. You have to do a field on that person. What will be the field in an amblyo? Will it show anything? No, it'll just be diffusely depressed to match their acuity. There better not be any vertical step. There can't be a fellow eye involvement. There can't be any RAPD. There can't be any OCT abnormality. This is your obligation. You must have amblyogenic etiology. You must swing that light, make sure there's no RAPD. You must do a visual field. The optometrist didn't do any of that, just said lazy eye, come back in a year, and the NLP was the result. All right, this person has bilateral small. You see how small the pupils are? They don't react to light, but this is the near reaction. So they have bilateral, small to pinpoint, but it's not tonic. Just small, irregular, became smaller and pinpoint. Poor light reaction, good near reaction. What's the name of this thing? Light near dissociation. When it's small pupils, irregular, that became pinpoint, and have light near dissociation, what's the name of this pupil? Argyle-Robertson. What's the cause?
Neurosyphilis.
Syphilis. Where's the lesion? At that pretectal afferent. Remember that little pretectal afferent? The light reaction is poor. The near reaction can still talk to the Ettinger-Westphal nucleus, light near dissociation. It's disconnected the pretectal afferent from the near reaction. What's the acuity in the Argyle-Robertson? Normal. What's the slit lamp? Pressure, motility, fundus exam, OCT, all normal. The only thing this person has is small pupils that don't react to light but do react to near. This is the tectal problem, yes? There's not going to be any acuity loss. There's not going to be any RAPD. It's bilateral. You're about to send out a syphilis. So where is the lesion? Pretectal afferent in the dorsal midbrain. What questions would you ask? Where are you from? What have you been doing? Yeah? What else would you do on an exam? Look for uveitis, rash. What's the most likely diagnosis? Argyle-Robertson. And if in Argyle-Robertson, the most common cause is syphilis. And you have syphilis here in Kuwait, don't you? Yes. Why? Every country has syphilis. Every country. Doesn't matter what country you have. Yes? I've been to some countries where they literally said, we don't have that here. I'm like, nah, you don't know human nature. Yes? So you can get a RAPD right here, tectal RAPD. If it's bilateral disease, you'll get the Argyle-Robertson pupil. So you have to do an MRI of this to make sure there's no dorsal midbrain compressive lesion, and you have to test them for syphilis. So bilateral, small irregular pupil that constricts the near, Argyle-Robertson. Syphilis serology. It's a sign of tertiary syphilis. So there's stages. First stage, chancre. Second stage, uveitis rash. Third stage, late or early latent, and then neurosyphilis. However, CDC says if you have pupil involvement, you have tertiary neurosyphilis. That means intravenous penicillin. If it's any neurop case with syphilis, it needs penicillin intravenous. They also need spinal tap. Okay. All right. How about if it's bigger pupil, but good near reaction, but anisocoria? This one is the adhestonic pupil. It's bilateral. So the Argyle-Robertson, small to pinpoint. This one, not small. You see how they're not small? They're bigger. And when they constrict, the light near dissociation is not symmetric. It's because it's a bilateral but sequential adhestonic pupil. They had adhes last year, now they have adhes again. I do the syphilis serology on this too. So unilateral addies, we don't do the syphilis on. Bilateral, you do the syphilis. You understand? Bilateral is systemic. Got to do the syphilis serology, even though most bilateral sequential adiastonic people are not syphilis. Not syphilis. You have to scan both of those. So bilateral light and ear, you have to scan it, MRI, to look, make sure there's no lesion here at the pretectal, and syphilis serology. Two types of syphilis serology: treponemal antibody and a non-treponemal. You have to do both because the treponemal, once it's positive for life. The non-treponemal is a marker of activity of disease. Yeah, all the ones with T are treponemal. So TPPA, treponemal pallidum plasma agglutination, MHATP, microhemagglutination for treponemal pallidum, syphilis IgG for treponemal pallidum, FTA, ABS, fluorescent treponemal antibody. You know all those? So which one are you guys have?
We use the PTR and TPHA.
So TPHA is the treponemal pallidum hemagglutination. That is a T, treponemal test. The two with no T are the non-treponemal tests. You have two. One is VDRL, Venereal Disease Research Lab. The other is RPR, Rapid Plasma Reagent. So you have two non-treponemal tests. They don't have a T, RPR and VDRL. And then you have a million treponemal tests. They all have T. You have to have both. So if both are positive, you have it. If the treponemal test is positive, but the non-treponemal is negative, they have to have proof that they received penicillin before. If they cannot provide this proof, you have to treat. If the non-treponemal is positive, RPR is positive, but the treponemal is negative, you have to do a second treponemal test. So if you're starting with TPHA, you have to switch to MHATP or FTA. And if two treponemals are negative, but the non-treponemal is positive, that's a false positive RPR. You got how you do this? If they're both negative, you're done. They don't have it. You need both. Okay? All right. This person was seen in plastics, and plastics wrote Perla. What did I tell you was missing from Perla?
D.
The D. So let us look at this person in the light. Do you see the light? But now in the dark. What do you notice in the dark? You see the anisocoria in the dark. Is that anisocoria present in the light? Nope. And plastics was about to lift up that levator lid right there. Yes? You must test in the light and in the dark. If I just show the top at a plastics meeting, they'll all start talking about surgical procedures. You see how little ptosis, little pupil is big problem. All right, we put a drop in the eye. What was the name of that drop? Aproclonidine. It's alpha 1 or alpha 2. It's alpha 2. But if you have a denervation supersensitivity, alpha 1 will predominate. And what will happen to the little pupil? It will dilate. That reverse this anisocoria. It also reversed the ptosis. You see the ptosis is gone too. So what's the diagnosis here? You almost did a levator advancement on a Horner syndrome because you only tested in the light, not in the dark. Do you know how many plastics people would just pass this person right here? Yes? Wouldn't you pass this person? They have nothing. Look at their thing. Now, I can see they have anisocoria because it's a 0.5 millimeter, but in the general clinic, this is just going to fly right past them. Yes? You must test in the light and in the... This is a Horner's. Should you worry or watch? It's a huge worry. And if it's acute and painful, what are you worried about? Dissection. You almost did a levator advancement on a carotid dissection. What's the name of this sign? And what's the name of this black thing, this void in the signal created by flow? That's the flow. Do you see it now? This person was sent for levator advancements. Do you see the anisocoria or not really? Do you know how many people would just pass this? Yes? Aren't you going to want to raise that? Doesn't it look like high in the strength will increase to you? Yes? It's just straight up levator distance, isn't it? Okay, in the book, it's always so obvious the Horner syndrome in the book, isn't it? It's like so obvious that they have a Horner syndrome. And it's always a young person. You know why? Because young people, they don't have levator distance. So the book, Horner's, so obvious that they have Horner syndrome because they're a young person. How about old guy in your clinic who's, do you think this guy's going to say, hey, I have a Horner's, or is he going to say, I have a droopy eyelid, and I'd like you to fix it? Yeah? Baseline. You see the ptosis? Cocaine. What happened to this pupil here? Did it dilate compared to the control? That's a Horner's. And aproclonidine, it reversed the anisocoria. So cocaine works by inhibiting the reuptake of norepinephrine. It won't dilate. But aproclonidine does the opposite. It will dilate. You understand how to do these tests? What happened to the lid when I put in aproclonidine? It opened because that is a direct acting sympathomimetic. What happened to the lid though when I put the cocaine? Nothing, because there's no norepinephrine in the junction to inhibit the reuptake of it. So the pupil doesn't dilate, the lid doesn't move. All right, now there's this one extra thing I want you to look at now. Do you see the lower lid here in the left? What do you notice about the lower lid? It's a upside down ptosis. Do you see it? So the gravitational field of this planet only works this way. There's nothing that can fight gravity like this. So in every single patient that you have with ptosis, you got to look for upside down ptosis. That is a way more powerful sign than the ptosis. Do you see the upside down ptosis? This guy's got this like little bit of like laxity in his lid, yes? Do you see where the lid is versus the limbus? So in every single ptosis, you must look for upside down ptosis. Upside down ptosis is always pathologic because you're going the wrong direction against the gravitational field of this planet. Yes? Your face can't go up spontaneously. Your breast can't go up spontaneously. It doesn't work like that. Everything goes this direction. And you must image from the hypothalamus, how far down? T2. And you got to ask them about chiropractic manipulation. You have chiropractors here. You don't have this. They move the neck. You have? All right. This lady, she's a model. She posted this. Pinched a nerve in my neck on a photo shoot. Got adjusted with the chiropractor this morning. It really hurts. Any home remedy suggested? Loves and kisses. That's her kid. Yes? That was the last known post of that woman because less than an hour after that post, she collapsed and died after having chiropractic manipulation. Cause of death, vertebral artery dissection. When they manipulated her neck, the Horner's was already there. She had a tear. When they did the neck manipulation, it killed her. If you go to the beauty parlor, when they're washing your hair, what do they ask you to do? Can you scoot back? Guess who's washing your hair? The Reaper. Don't do this. Yes? You must plank. You plank? Don't. When they say bend your neck back here, that's a non-physiologic hyperextension of your vertebral. It'll stretch your vertebral artery. Don't do it. Okay? When they say scoot back and scoot back, don't you sometimes feel like you're gonna pass out a little bit when they tell you to do that? You're like, oh, I feel a little loose. Don't do that. Correct way. See straight? Too much hyperextension. Reaper, washing your hair. Yes? is a roller coaster. Yes? So at the top of the roller coaster, they take this picture right here because they sell it to you at the bottom. Yes? Once you got to the bottom, what do you notice? Ptosis. Anisocoria. Do you see it? This section. See that carotid from the roller coaster. So you're buckled in there, but your artery is not buckled in. Yeah. She literally has a photograph of the exact moment that her carotid occluded. And they sold it to her. At the bottom, you got a picture of yourself getting ordered. You got to worry about this neck pain thing. So, small pupil, small ptosis. Got to check the anisocoria in the light, but also in the dark. You're going to give that drop. What's the name of the drop that you have? Aberclonidine. It reverses the anisocoria. MRI, head and neck, all the way down to thoracic T2 in the chest. You're the hero of this story. Yes? Hero. All right, this is one of my referring docs. He gave me permission to show you. I'm not showing his name. He had acute headache, ptosis, and meiosis. And he sends me an email over the July 4th holiday. It says this: if you're willing, I'd appreciate your thoughts and guidance. I had a headache yesterday with gradual onset of ptosis and meiosis. Anisocoria more in the dark than the light. No disc edema, vision normal, no medical history, mild cough. Why is that cough relevant? The Valsalva. Yeah? Getting MRI, brain, neck, upper chest. Anything else you'd recommend? Should he wait for after the July 4th holiday to have this? July 4th is our Independence Day. He's not going to want to go to the hospital. So what do I tell him? Go to the hospital. It's July 4th. I've got people coming up. I don't care. The Reaper is in there with you. Yes? He said, I know, but I'm in the OR right now. And I have 14 cases. What should I tell him? Keep operating on people? Go to reschedule. I said, look, it's not just about you anymore. If you collapse in the OR halfway through this guy's case, he'll die or go blind because you wouldn't go to the hospital. I said, yeah, but it's just a little ptosis and a little meiosis. So I said this, send me selfies right now from the OR. Yes? This is what he took. He said, I already asked my buddies, they don't hardly see anything. How come? It's in the light. Yes? Go to ER now. Leave OR. CT, CTA. Take aspirin if it's a dissection. Image the whole pathway. This is what he sent me afterwards. MR with contrast shows 90% probable internal carotid artery dissection. Requesting CTA, heading to ER to meet neuro, wondering if prognosis is different if I come to Houston, or if you know anyone in the Dallas-Fort Worth area. Should I tell him to drive from Dallas, Texas to you? Go to stroke center, 4-stroke workup, by stroke doctor right now. Yes? Please don't stop at the chiropractor or go to the beauty parlor on your way down there. Nobody cares about your hair. Yes? Next time you go to the beauty parlor, don't forget the Reaper is washing your hair. Is this a worry or a watch? I saved my referring doctor. I also saved the other people he was going to operate on that day. Do you understand?
Sometimes as doctors, we don't think it can happen to us.
You definitely don't think it's going to happen to you. Yeah? All right. This patient has an acute partial ptosis, little pupil, big ptosis, but only partial. Should you scan that?
Yes.
What's our imaging study of choice? CT non-contrast. It was normal, followed by contrast CTA. It showed that. So partial pupil, Partial palsy, partial ptosis, irrelevant. Any combination of anisocoria and lid is third nerve palsy until proven otherwise. The only one that's not the third is little pupil, little ptosis. Any other combination is third nerve palsy. Big pupil, big ptosis, that's the obvious one. Little ptosis, big pupil, that's still third. Little pupil, big ptosis, that's still third. Do you understand what I've said? So the amount of ptosis that you're allowed to have with the Horners is only 1 millimeter because the Mueller's muscle, the sympathetic muscle, can only do 1 millimeter of ptosis. As soon as you start getting 3 or 4 millimeters of ptosis, that's third. Okay. Jury determines doctor missed aneurysm, award brain damage person $8 million. Blank recently won an $8 million medical malpractice lawsuit against the radiology group because they misdiagnosed the blood vessel and she was left paralyzed. In September 2020, she collapsed after experiencing the worst headache of her life. The ER doctor ordered a brain scan, but they didn't do the angiogram. And then they said, you have migraine. 12 days later, she collapsed again, awakes in the hospital. She is aphasic, cannot talk, and is paralyzed. I'll give you $8 million right now. I'll take your voice, your life, your walking, your talking. Is it a deal? I'll give you $8 million. You want it? You want that $8 million? I don't want that $8 million. I want my life back. Yes? This is from the Emory Group. Underdiagnosis of PCOM aneurysm after already having an imaging study. They already had a scan. 3 groups. 4 had subarachnoid hemorrhage. That's easy. So if CT non-contrast shows subarachnoid hemorrhage, you're done. Go home. Have dinner. Neurosurgery has to stay there and work on this case. Yes, you're done. You find out tomorrow on the EMR what happened to him. Group 2, they diagnosed the aneurysm. But look at this group 3. 8 people. 8 out of 17. That's almost half. The aneurysm was missed. And they reviewed these studies at Emory, and it showed it was not the technique, it was mistaken interpretation. Absence of specific training in neuroradiology and inaccurate clinical information provided to that person. Average aneurysm size 7.3 millimeters. Conclusion of this study, missed it. Aside from an accurate history, training, and experience of the interpreting radiologist is probably the most important factor in determining the reliability of a non-invasive scan and isolated third nerve palsy. So, if you've got a third, you have to tell radiology, I'm worried that this is an aneurysm. It's your job. That didn't happen in Bangladesh. That happened in Atlanta, Georgia. How about this? It's a kid. Is this a worry or a watch?
Right.
Worry. The thing you're worried about is a mass in the sympathetic chain. And the name of that mass is called neuroblastoma. The most common cause of a Horner's in a kid is birth trauma. But if it's an acquired non-birth trauma case, you have to scan it. And the scan is the whole thing. Even if it's birth trauma, it's still going to be litigation, okay? So this is a $2 million verdict because they had a Horner syndrome. Horner syndrome. All right, this person has anisocoria, poor light reaction. I put in 0.1% pylo, and this big pupil constricted. No ptosis, no motility deficit. Is this a worry or a watch? It's a watch. What's the diagnosis? Caries. So we don't image or do any tests on unilateral antistonic pupil. You're done. Your main job, make sure it's not third. But what if it's bilateral? You have to image because it could be right here. What if it's small to pinpoint? That's Argyle-Robertson. What if they have dorsal midbrain findings? You have to scan it. How about unilateral? You don't have to scan that. that lesion is here. Ganglion. Don't have to scan. All right. I'm just going to show you the Addies now. So this is Addies. You see it's small and irregular. See that? Infrared shows its vermiform sector paresis. See the pieces that are dark can constrict, but the parts that are not dark can't. And we know it can dilate, because again, tropicamide. And the thing that's tricky is when it's acute. So in the acute setting, that pupil was big. It only became small later. So 6 months later, it's getting smaller, 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 and has light near dissociation. So is Addie's a worry or a watch? Don't worry. All right, this is a 24-year-old nurse. She has this dilated pupil. She has no ptosis, no motility deficit. But it's this huge ass pupil. What drop would you put in there to prove, don't worry about it, you touch something and put it in your eye?
1%.
Pylo, 1%. The most common cause for that big pupil like that is this inhaler thing. So that's atrovent, and atrovent is atropine. And if the thing slides up and miss their eye, they get that. This is our number one cause in our hospital for anisocoria in the ICU. So we put Pylo 1% in there. See this big pupil? It didn't do anything after 1% Pylo. Is this a worry or a watch?
Not a watch.
It's a watch. You watch for what? For it to go away. Also wash your hands if you're a nurse. We did a hand washing study in our hospital. The least compliant, the ophthalmologist. This is the belladonna alkaloid. It's called Jimson weed. You have this plant here? That's the most expensive Georgia O'Keeffe painting ever sold, $38 million. If you get that in your eye, your pupil will die. So is this a worry or a what? Yeah, don't worry. Be happy. So you should now know that big pupil, big ptosis is big problem. That's third nerve palsy. Big pupil, little ptosis, that's also third nerve palsy. Little pupil, little ptosis, that's the Horner syndrome. That's a big problem also. And my friend was going to continue operating on people, even though he had a Horner syndrome. Don't do that. Little ptosis, big, little pupil, big ptosis, that's still third nerve palsy. So 3 of the 4 combinations are all third nerve palsy. And so we actually don't use liberal little pupil anymore. Everybody gets CT, CTA, followed by MRI, everybody. And any normal pupil with RAPD, that's bad. So you should now know all of these pupil things now. You got all these pupil things now? All right. In this last bit, because I'm going to let you go early, I'm going to just show you what we do with NASA. But before I do that, I'll let you ask me any question you want to ask before we do that. It doesn't have to be about the people. Because I only had 2 days with you. But look how much you've learned in just 2 days. I didn't even have full days. You guys finished at 2. We don't finish at 2. Yeah. So come visit me on YouTube. Okay? Come visit me. All right. You start at 9 o'clock? What?
No, it's not at 7:30.
Yeah.
Have lunch break. Have coffee break.
You have a coffee break? Yeah, we don't have any of that. All right. I want to tell you about what we do with NASA. Remember I told you that little kid who wanted to be a doctor and a Jedi Knight? His second choice was actually work for NASA. So I work for the National Football League, which is our football. Your football is soccer. Our football is American football. I work for the United States Department of Justice and NASA as a neuro ophthalmologist. Because neuro op for me is more than just a job. It's a calling. I try and bring neuro op to every single thing I do or touch. I'm interested in the ophthalmology and the neuro ophthalmology of sports. I'm interested in litigation and lawsuits. I'm interested in flying in space. I literally wrote a book called Spaceflight Associated Neuroocular Syndrome. I have seen every single case of this disorder, which is an extraterrestrial disorder. There are no cases on Earth. It only occurs in microgravity in space. It's called spaceflight associated neuropathy. I just want to end also with a story about myself so that you'll understand me better. Because now we are quantumly entangled. Your future, this present, and this past are all together. Weirdly, you already are in the past. It takes about 100 milliseconds for my voice to travel the air, get in your ear, vibrate your tympanic membrane, and get in your auditory cortex and then be processed. That means everything I'm saying to you right now that you are perceiving as the present already happened. That's a weird concept, don't you think? When you look up into the sky, the night sky, and see stars, some of those stars supernovaed 100,000 years ago. Every person, every plant and animal in any surrounding system around that star is gone. But because it took so long for the light to get to us, their past is your present. You with me on this concept? And that means what you are perceiving as my voice right now already happened 100 milliseconds ago. You know that because if you touch something hot, it's like, but it's delayed because it took time. And if you feel your hand, you know that your hand was on there longer than you thought it was on. You understand what I've said? You are living right now in the past. There is no such thing as this. Like literally, I could have already died 100 milliseconds ago. You will not know it, and I will not know it for another 100 milliseconds. That's weird. But we have a shared future now. So I want to take you to that future. We're going to go back to the future. To go to that future, you have to understand my past. That's my grandfather there. My grandfather's name was Yu Pin. In this photograph, he's 95 years old. He has 13 kids, including my father. That's my dad. Every person in this room has an academic family. This is my academic family. That's me. That's my academic father, Neil Miller, Johns Hopkins Hospital. And that is his father, Bill Hoyt. My grandfather, my father, academic grandfather. Everyone in ophthalmology is connected by less than 6 degrees of separation. Whoever trained you was trained by somebody, and that person was probably trained by somebody, and everybody in ophthalmology can get all the way back to a single common ancestor. Usually you can get there within less than 6. Less than 6 degrees of freedom. This is our past. Our past is a Roman past. We share this past. And the road. You see the road? Because the vehicle at the time was this, the Roman chariot. It was defined by the width of these 2 horses' butts. So 2 horses, then chariot, wheels. So the wheelbase is determined by 2 horses' butts. Because the chariot, that thing, is the standardized transport of the empire, and all roads led to Rome. The road has a rut in it. You see that rut? It's like this. And you can't change it now because you can't make the wheels bigger because it won't fit. You can't make it smaller. It won't fit. So everybody has to do this. So after hundreds and hundreds of years, you get that. You see that rut there? And what that means is even if you change transportation, the width just stayed the same because you didn't build a new road. You just used the road that was already there. And even when you got rid of the horses and just have horsepower now, steam power, it's still the same. And in our country, we built a railroad called the Transcontinental Railroad. Started from the east and went all the way to the west. In order to do that, you have to standardize the rail. The standardized rail, 4 feet, 8.5 inches, the exact same as the Roman road. Became the standard. So now back to space. This is our solid rocket engine booster. It's built in Utah, and then it has to transport all the way to Cape Canaveral, which is in Florida. Can't ride on the road. it has to ride on the rail, which means the width of that cannot exceed 4 feet, 8.5 inches. Because it has to go through the tunnel with the rail. The Romans. So SANS is space flight associated neuroocular syndrome. SANS is what we call it. It's characterized by optic disc edema, globe flattening, choroidal folds, and a hyperopic shift. It's only seen in astronauts after long duration spaceflight. So what happens is you have no gravity in space. Normally, as you're sitting there right now, the gravitational field of this planet is pulling all your fluid down like this. And so your heart has to pump against that gravity. If you go into space, you don't have that anymore. That hydrostatic gradient created by gravity is gone. And so the fluid just gets stuck right here. The fluid flattens the globe. It causes a hyperopic axial shift. It causes choroidal folds and disc swelling from lack of gravity. So in 2003, that's the very first time we ever saw choroidal folds in an astronaut. All the program before, Apollo, Gemini, too short of a duration. But once we built the International Space Station, people stayed on there longer and longer and longer. And so we saw a new disease, an extraterrestrial disease called SANS. In 2005, disc edema and a cotton wool spot. I'll show you what that spot looks like. Half the people that fly on the International Space Station, the IAS, get this refractive shift, and they have to have stronger reading glasses. And that paper was the very first description of the extraterrestrial disorder SANS.
The shift is permanent.
No, it goes away as soon as you return to the gravitational field of the planet.
Everything goes away.
Everything goes away. And then we had recurrent findings in a repeat flyer. And then we had a pigment epithelial detachment at central serous retinopathy and an intraretinal cyst from a thickened pachychoroid in 2022. So back to my grandpa. You see my grandpa there? My dad? My grandpa's name was Lee Sai Do. Upin is what he went by. He was born on April 19th, 1903. In the year of my grandfather's birth, the Wright brothers flew an airplane for the very first time. In 1903, the emperor was still the emperor of China, and my grandfather was a citizen of the empire. He moved to the Manila, Philippines at age 36. He was a janitor. My grandpa was a janitor. He worked in the Li Chingchuan lumber company. He was not literate in the language of his new country, Tagalog, the Filipino language, and he spent 50% of his salary to learn English because he decided he was going to emigrate to the United States of America. He taught himself English. Instead of cleaning up the trash can, he was reading the newspaper in the trash can. On one side was his language, Mandarin. On the other side, English. My grandfather had 12 children and adopted this guy, my Uncle Philip. Uncle Philip is the oldest child because my grandparents went 2 years, no children. And in Chinese tradition, the way to have children is you adopt a kid. They adopted Uncle Philip. And the very next year. And every year that followed, they went from having no children to 13 children. To this day, my grandfather believes that it was the adoption of Uncle Philip that caused that. He believed that. And that's my dad. My parents are doctors. They're both internists. They trained in New York City, New York. Their hospital now is called Montefiore. Okay, this is my grandpa, just to show you how we are connected in a weird way. This is my grandpa. He was born in 1903. The Wright brothers flew in that same year, Kitty Hawk, radio, Model T, television, the atomic bomb, and on this date right here, July 20th, 1969, my father, my grandfather, and I all watched man land on the moon at the same time. Because my grandfather lived to 2006, because he did not die until 103 years old. He saw every single thing that you use now, even though he was born in the year the Wright brothers flew. Do you see how connected we are? In one generation, I am connected to 2 world wars, flying, man on the moon, and every single thing you know right now. My grandfather, Yupin's son, had 3 children. This one's me. This lady is a hospice doctor. He's not a doctor. He's smart. And my children. So thank you so much for these gifts. This girl's 24 now. She works in oil and gas. Next year, she goes to medical school. But weirdly, on July 20th, 1969, I was 5. My father, my grandfather, and I watched this show. It was on our TV. Our TV was black and white. It said this, live from the moon. All the channels were on the same TV show. It is the most watched television show in the history of this planet. 1 billion people watched this show. Even if you change the channel, it wouldn't make any difference because they're all on the same show. And we only had 3 channels, ABC, NBC, and CBS. Houston, my hometown, was the very first word spoken from the moon that day. Houston, tranquility base here. The eagle has landed. And I told you a long time ago in a galaxy far, far away, that guy, but he had a secret dream. He wanted to work for NASA. And when I was a kid, I watched this TV show. It was called Star Trek. And all my buddies wanted to be this guy, Captain Kirk. Because Captain Kirk got all the girls and always was the hero. This guy was just the science guy. I never wanted to be Captain Kirk. I always wanted to be the science guy. Always. In 1965, 2 years after my birth, NASA decided that they want to build that thing right there. It's going to measure acuity and field. And they're going to fly this thing. This is what the device looks like now. This is what I'm aspiring to do now, to achieve the dream of NASA in 1965, to bring to you a NASA spinoff that we can use in the clinic, where we don't have to actually check people's vision or their field or do an OCT or check their motility or do any of the people. That machine right there can do all of it. In fact, they could do it at home or in the Avenues Mall. They can just go there and stick their head in there, and then all the data would just flow to you. And then you would say this, you have a cataract, we're going to take it out. You have no RAPD, you have a full field. Fundus showed OCT normal of macula and nerve. Your motility is full. You're scheduled for tomorrow. Please show up tomorrow. Would that be great? If you think that's science fiction, I'm just going to tell you right now, it's sci-fi, no fi. It's straight up sci. This is 5 MB of code. That right there, that ran our air defense system. It took that lady 5 days to put every one of those cards into there. Every talk I've ever given is on a flash drive here. I have a 5 gig drive. That's way more than the United States had to run the air defense system. Houston is home to the Johnson Space Center. Manned missions all arise from here. This place is called Mission Control. It's in Houston, Texas. So you can read more about the Neuro Ophthalmology of spaceflight and SANS if you want in these articles. You should know that we're part of a bigger team, the European Space Agency, the Canadian Space Agency, Japanese Space Agency, and our friends, the Russians. We have Emiratis flying this year. It's been a very mysterious syndrome affecting astronauts. You can see the lay press. Mysterious syndrome. Spaceflight bad for astronauts' vision. Astronaut eyes at risk from too much time in space. All astronauts have longitudinal medical surveillance. I'm not their doctor. I'm just their neuro ophthalmologist. They have a flight surgeon and flight optometrist. But we need to see why they can't see in order to go to Mars. So here's the problem. There's no gravity. Earth's gravity is 1g. You can see Mars is 1/3 of a g, and the moon is 1/8 of a g. So there's been no permanent vision loss in SANS. The treatment is ET come home. So when they come back to the gravitational field of this planet, it just sucks the fluid right back out. Come home. That's the treatment.
You just get subretinal fluid.
Not subretinal, but choroidal thickening. And you can see the longer and longer durations of spaceflight created by the International Space Station. This is why we never saw it before. We start seeing SANS at 3 months in space. And our longest flyer is now Peggy Whitson, 665, female astronaut. In 1969, all our astronauts were male, white, test pilots, military. They also all drove the same Corvette. But in 2019, you can see our astronaut corps looks more like the United States of America looks. We have female flyers. In fact, we had an all-female crew just recently. On the International Space Station, we have visual acuity, AMSR grid, OCT2, and ultrasound. We also have a fundus camera. I told you that hyperopic shift, we have these space anticipation glasses. See that bar in the middle? You can move that little bar. It changes the silicon in that lens and changes the refractive index to account for the variability in the refractive change, which is usually between plus 0.50 and 1.5 diopters of refractive hyperopic shift caused by fluid in the orbit, compressed the globe, causes this. Now, of course, we have way more reading glasses up there. Don't need this anymore. So here on Earth, reading glasses, but in space, this was temporary until the reading glasses could be launched. Astronauts on the station check their own vision, pressure, OCT on themselves. Could have been IOP. Here on Earth, hypotony causes choroidal folds, disc edema. But we know the intraocular pressure goes up a little bit and then goes back down and stays stable. So it's not hypotony, it's not intraocular pressure. So the astronauts check their own OCT, ultrasound, and fundus photography on themselves. There's no tech, there's no nothing. They just do it on themselves. So this is the change in one of the astronauts' flight day, launch plus 90, and there's this peripapillary change right here. We have OCT2 on the station, so you can read about the OCT analysis on the International Space Station in JAMA. And in that show, Star Trek, they have gravity. All shows about space have gravity because it's just too expensive to show people floating around. But artificial gravity is super expensive. It's not that it can't be done, it can be done. It's just too expensive. So on TV and the movies, there's always a roof and a floor and seats, just like home. But on the International Space Station, there is no roof, there is no floor, and it's not clean at all. There are wires all over the place. So this is what a real spacecraft looks like. And in this designation, the OCT is at the top there, but there's no top, there's no bottom, there's no gravity. So they just float on up there, and they do an OCT on themselves. So this is case 3 from our original cohort. You can see pre-flight what it looked like, and then post-flight, you see the disc edema. OCT shows the black line is going off the page. So this is true disc edema that is occurring in flight. And then when they come back to Earth, that's launch minus 32, return to Earth plus 5, return plus 18, return plus 41, return plus 80, return plus 225. So by 225 days return to Earth, the disc edema that was present on the International Space Station is gone. You see that? The other weird thing that happened is, see that where that return plus 21 days is? Right at the junction of those vessels, at return plus 48 days, a cotton wool spot appeared right there. That cotton wool spot is probably from being struck by a high energy cosmic ray. So right now, we are protected by our atmosphere and our magnetosphere from these high energy particles that are coming off our sun, and the high energy galactic particles, pions, kaons, they just get absorbed in our atmosphere. But in space, there's no protection against these things, and so it just hits them. Astronauts on the station report sometimes that they see a flashing light, and then they get this cotton wool spot. So I think it's a form of localized radiation therapy, but we really don't know what causes this. So here's choroidal folds that developed on flight day 90. You see baseline right and left in the choroidal folds. If you do the reconstruction, you can see it's a Friesen grade C-shaped halo of disc elevation and the choroidal folds. All of this occurs on the station, flight day number 90, 3 months on station. And this is, you can see that little volcano, pre-baseline OD and OS against intra-flight, that's flight day number 90. So on flight day number 90, this person is starting to get Friesen grade 1 disc edema and choroidal folds. And if you do OCT through there, you can see it's choroidal folds and synchronous and asynchronous retinal folds as well. My friend Dr. Killer has a hypothesis about this, that the fluid gets in the sheath and this is pushing on the back of the eye. So here's the fluid on MRI, flattening of the globe, same thing that we see in terrestrial pseudotumor cerebri. The fluid's trapped in those little trabeculations. So my friend Dr. Killer's hypothesis is the bottleneck occurs in the canal, the fluid gets up here, cephalid fluid shift, can't go back down because there's no gravity, and it just pushes on the back of the eye, causing the choroidal folds to disc hyperopic. So this is a cartoon demonstrating on Earth. You have the dura connected to your head, and then the fluid gets stuck here, expands the dura, flattens the globe, causes the disc edema, choroidal folds, hyperopic. This is the predominant theory of the microgravity-induced spaceflight-associated neuroocular symptoms. We know it's not central venous pressure because we had central venous pressure measurements, no change in microgravity. We can't do a spinal tap to measure intracranial pressure. There have been spinal taps on the ground, which are borderline. And then the predominant theory is that it is the Killer hypothesis, cephalid fluid shift into the orbit. So this is what that cephalid fluid shift looks like. You see on the ground the hydrostatic gradient created by G. Everything gets stuck upstairs in the head and in the orbit. You can see it changes their facial features. This is Peggy Whitson. She flew the 644 days. You can see the change in her face in the photos from the cephalid fluid shift. This is the crew of Odessa. You can see from the European Space Agency pre-flight, and you can see when they're in space, they get this moon faces. So pre-flight, post-flight. So here's the predominant hypothesis that you have a hydrostatic gradient that's pulling on you right now from the G. The stuff gets upstairs, it's chicken legs, facial profiles. We do have a countermeasure. It's a negative pressure generator. So you put stuff in here and it sucks the fluid back out. So it's a lower body negative pressure device that pulls the fluid back out. Unfortunately, since the war started in Ukraine, we have no access to the device, which lives in the Russian sector of the space station. It's called the Chivas. I do not speak for the United States government now, but we have no access to the Russians. It's been tested here on Earth, so we can generate a fluid shift by putting people in the head down position. So if you're head down, the fluid will go down there, and we can use the lower body negative pressure, pull it back up, and it does reduce the fluid. And we have OCT before the war showing the Chivas can suck the fluid. CO2 was considered as well before, but it's clearly not CO2. Normal operating performance measures. We do have a terrestrial analog, which is called head down tilt. So if you lie in bed, head down, we can generate the cephalid fluid shift. However, you have to be in bed for a long time. So this is the negative gradient, 6-degree head down tilt, causing the fluid shift that replicates SANS. 14 days of lying in bed. 14 days in bed. 14 days. 30 days in bed, just lying there. After 30 days, you start to see some change in the nerve fiber layer, even though we don't see anything ophthalmoscopically. 14 days, barely anything happening, no photo change. 70 days, 2 months in bed. And now you start to see something. 2 months.
Face down.
Head down. These are some crazy people. They do get paid.
Yeah.
They also have to do psychological screening before. It's usually medical students.
They need the money.
You can see at 70 days, 2 months of lying in bed. Now, the same thing that happens to these bed people is the same thing that happens when the astronauts come back. So when the astronauts come back, they can't stand up, because if they stand up, they'll pass out. Same thing happens to these people. They get like weak bone loss, muscle mass loss, deconditioning. If you add in a little bit of CO2, you can see the total retinal thickness starts to be increased. If you do an MRI on these people, you can see pre and post bed rest that the ventricular volume is changing. You see the ventricle volume because the fluid shift. You can read about this in the New England Journal of Medicine. Narrowing of the central sulcus, upward shifting of the brain, narrowing of the CSF space at the vertex. So you can see they have fiduciary markers that show the cephalid fluid shift from being head down. And also the astronauts have the same thing. So if you pool all the patients, and there's not that many patients, okay, because we only get a new crew every 3 to 6 months. So nobody had permanent vision loss, no effect on cognitive function. 69% of the people had some finding of SANS. The most common is viscedema, then choroidal bulbs, then glow flattening, and the hyperopic shift. And it's thought to be related to dose. It's a dose effect from duration of the. We have an animal model, which is we can do this to rats by hind limb. You can hold the rat upside down, and it'll force the cephalid fluid shift. And we can see this is a model for SANS. We have a microgravity model here on Earth called the Vomit Comet. This plane has been modified. So during the 1.8 G ascent, at the very top of that parabolic curve, you have zero gravity for about a minute. Believe it or not, someone flew with an Omiya reservoir, and they tapped it during the flight, and no change in pressure. Also, no change in central venous pressure on the Vomit Comet. You might say, why don't you just do a spinal tap? We used to have the shuttle, but the shuttle went away. But if you come visit me in Houston, we have a shuttle, but it doesn't fly. It's just a model. Our astronauts make a hard landing in Kazakhstan, in the former Soviet Union. This is Kazakhstan. It's a 4-hour helicopter ride from the landing site to the middle of nowhere, Baikonur Cosmodrome, in the middle of nowhere, Kazakhstan. Russians. Kazakhstan is super far away from Houston, Texas. So we have no spinal tap, we have no OCT, we have nothing on the ground in Kazakhstan because it's the middle of nowhere in the Baikonur Cosmodrome. However, SpaceX, Elon, returning to warm water landing, so maybe we'll be able to do some of these tests. All right, I want to just go back to what I told you about and then end our time together, because what I really wanted to share with you is we have a shared connection now. It's deeply ingrained in us to do this. Science, it's in our bones, in our blood, in our DNA. So in 1965, NASA envisioned this thing. So what we're working on is making that thing a reality. So this is a multimodal direct and indirect goggle-based system. And we're trying to test the field, generate a synthetic image of the MRI, and a synthetic image for the things we cannot test for. So this would be a completely head-mounted portable device with interchangeable units. So you would put in the pupil thing and the visual field and an OCT, all would be interchangeable. Ideally, it would be printable on Mars with 3D printing. We would not have to send it. We would just print that when we got there. Print the slit lamp, print the everything, the ophthalmoscope, print everything. Just bring the lenses. Everything else, the housing, the chairs, everything just printed on planet. Because it's super expensive to bring all this stuff to Mars. So this is the virtual reality stimulator that we have. So we can pretend they're going to the eye doctor. So they can literally wear this thing, walk around, sit down, how's your vision, check their vision. So this is what the engineers made as a prototype. I said, you need to put some plants in there or something. Make it look, this is what an engineer thinks. I meant by putting some plants in there. Like, these guys need to get out more, don't you think? Like, that is not what the eye clinic looks like. Look, this is what they do. Anyway, it doesn't matter what it looks like because we can do contrast sensitivity. We can do Amsor grid in these goggles. Can't do a Humphrey yet, but it's getting there. So you can test the visual field with the goggles. These already exist on Earth, by the way. The idea is to make it look like what we see on Earth. It's getting there. So my job is to make sure that mathematical models that they are using generate something that looks to us like what we see here on Earth. So these are called generative predictive models. So we don't have fluorescein and we won't have the camera on Mars. So we have to use data to generate a synthetic image. So a synthetic fluorescein and a synthetic fundus photograph will be generated by the data collected by the goggles. So all this generative adversarial network in the black box, I still need it to look like what we on Earth can interpret it as a signal. And so my part in the job is make sure it looks like a fundus photograph, make sure it looks like an OCT, because reams and reams of data are just coming out of this thing. So I guess what I'm really trying to tell you is we're trying to aspire to terrestrial health applications of the visual assessment technology, including machine learning that we're using in spaceflight associated neuroocular syndrome. NASA calls this a spin-off. Every dollar that goes into NASA produces $7 in the non-NASA terrestrial economy. And my piece is not to develop predictive machine learning, but to make sure that what comes out the other end is useful to clinicians. So what's in that black box? So we already tested this on a game that we used to call at Iowa Real or Fake. So you plug in this data, which is fundus photographs, and you ask the machine, is that real disc edema or pseudoedema? A game we used to call Real or Fake. So in the clinic, the docs could only get like 50% correct. But the machine, way better than the doctors. So the machine is like 90% in the Real or Fake game. It can literally tell the difference between true papilledema and pseudopapilledema. And it can do it way faster than us because it has reams and reams of data. And it can be taught. So the goal is to teach the machine what SANS looks like. Teach the machine what spaceflight associated neuroocular syndrome. On Earth, we can do it with bigger data sets because we have papilledema and pseudopapilledema. And that's the goal. We'll have a spin-off. I totally envision a day where ophthalmologists do not have to do anything except operate and use their brains to figure out what's wrong with people. The rest of the data collection is done by machines. Astronomers used to spend weeks and weeks and weeks looking out into the night sky, but now machines scan the sky. Modern day astronomers don't do that anymore. They just analyze data now. I told you on July 20th, this was our TV, and that Houston was the first word spoken that day. I want to tell you about a different day. July was the first day. April, the next year, 1970, was the second day. Houston was again spoken from space. This time, Commander James Lovell said this: Houston, we've had a problem. They made it into a movie with Tom Hanks called Apollo 13. This was the problem. They're spinning the spacecraft, and the oxygen tanks exploded right there. Big problem. Big problem. That's me, Commander Lovell. That's my daughter, Rachel, oil and gas kid. She's standing next to an Apollo fuel cell, 3 fingers. It takes 3 of those to come back from space. Apollo 13 had 1. When they called up to Jim Lovell, they did not say to Jim, Jim, you're going to die. They said this, failure is not an option. Failure is not an option. And Apollo 13 did come home with one Apollo fuel cell. On the ground in Houston, Texas, in the simulator, not a single astronaut could pilot Apollo 13 back. They all burned up in the atmosphere. But NASA did it with one Apollo fuel cell. That's my daughter, Virginia. That's the kid that's going to medical school next year. That's the kid that owns the YouTube site. That's the kid that never asked me for money. That screen was on the TV on July 20th, 1969. In black and white. Now you can touch it because it's at the Smithsonian. You have a million times the computer power that NASA had available to it in July 20th, 1969 to put a man on the moon and bring home Apollo 13 in 1970. And so you should use that phone for power. The power is, I'll be with you with your next neuro patient. You have a problem, you just Google it. My kid has given you a gift that I could never have imagined that I would be doing. A virtual access to me anytime, day or night, 24/7, 365. Come visit me on Notary. If you have a question, I'll answer it for you on YouTube. And if you come to Houston, Texas, you can come visit Mission Control. They kept it exactly the way it was on July 20th, 1969, including ashtrays and cigarettes and rotary phones. The real Mission Control is one floor above this. In the movie The Martian, you can compare directly the Mission Control of the movies against our real Mission Control, Houston, Texas. There's Virginia, she's in Mission Control. See how nobody else is in Mission Control? Because machines do all the work now. Human beings are there to monitor the machines. AI is here. Artificial intelligence, it's already here. You will either be its master or its slave. You must choose now. You must learn something about AI and start to use it. If you're within 5 years of retirement, you don't have to do any of this. But all the rest of y'all, get ready. I totally envision a day where machines will run what we do now, and we can spend our time doing what we do best. In the movie, The Martian, that was the thing that Matt Damon took out. This is the real one, tested in the desert. That's what I was thinking on July 20th, 1969. Instead, I became this. I told you I got to be Jedi Knight. I also got to work at NASA. I think Mr. Dorr would be quite proud of that little guy right there. I get to work with real rocket scientists and real astronauts at the Johnson Space Center, Houston, Texas. I get to be Mr. Spock, the science officer on our planned mission to Mars. I get to work in the Human Spaceflight Program. I celebrate my grandfather's birthday, even though he died in 2006. I would love to tell you my grandfather lived a clean life, never drank or smoked or did any of that. We drink at my grandfather's birthday party because that's what he would have done. We have a reunion. From the 12 children and the one adopted, there are now over 1,000 descendants of UPenn. In the United States, you can see we have a lot of white people in our branch of the United States UPenn family. We have a lot of blonde-haired people in our family because our astronaut corps doesn't look like it did, and the UPenn dynasty does not look the way it does. A janitor did that. A janitor who had vision, a janitor who had drive, a janitor who believed that he was more than a janitor. I wish my grandfather was here so I could tell him, hey, Grandpa, here's what I'm working on. Remember that day in 1969 when we watched man land on the moon? We're going to go to Mars, Grandpa. I told you I have my academic family. You are now part of that extended family. You are part of the family. From Rome to rockets We are interconnected now in a deeply meaningful way. We are quantumly entangled. From a NASA perspective, we are preparing for our mission to Mars. It is my goal to bring terrestrial applications to pseudotumor cerebri, vision loss, including NION, in the head down position, the same model that we have for SANS. And in 1903, Orville and Wilbur Wright flew for the very first time Kitty Hawk, North Carolina. The Smithsonian saved a piece of canvas from this flyer, the Wright flyer, and it was launched to the red planet Mars 118 years later. The Wright brothers flew on Mars in that helicopter. And so Houston was the very first word spoken from the moon that day. Houston will be the very first word spoken from Mars. Houston, Tranquility Base here. The Eagle has landed. And so I'm really excited to be a part of something bigger than myself. And I hope that you've enjoyed talking a little bit about spaceflight. I thank you so much for having me. I'll stay around if you have any other questions you want to ask me.